Yeah, that solves that. Oh my God. Healthcare without the patient seems pretty ideal. I'm Keaton Fletcher, an assistant professor of industrial organizational psychology at Colorado State University.
And I'm Mariana Arbon, an organizational psychologist who specializes in organization and talent development.
And this is Healthy Work. Welcome back to another episode of Healthy Work. I am over the moon. I am so excited to be joined by a close friend and an amazing researcher and colleague. I will get out of the way and let you introduce yourself.
Hi, everybody. My name is Lisa Kath. I am an associate professor at San Diego State University in the psychology department. I am an IS psychologist, but I also consider myself to be an occupational health psychologist.
Thank you so much for being here. I wanted to get you on for a handful of reasons. One, I love talking to you. Two, you recently published a paper in the Journal of Pediatric Nursing that I think is relevant to some awareness days that are coming up right now. This will be released the week of June 15th. And so just as a heads up to our audience, June 17th is National Nursing Assistance Day. June 11th to the 17th is National Nursing Assistance Week. And the month of June is National Safety Month. And so you have a paper that hits on a lot of these topics and speaks to this population. And so I was just so excited that you were able to come and talk to us about what you did, what you found in this highly relevant topic. So what is it? What did you do? What did you find?
First of all, I have to say thank you so much for having me on your podcast. I love your podcast, so I'm excited to be able to be part of it. So my study was looking at healthcare workers. That's been the focus of my research for some time. And we were interested in the psychological harm that can be done when people experience patient aggression. And so I'm using the term patient aggression. This is with the pediatric healthcare workers. And so I want to first of all be clear that the preferred term in pediatrics is patient behavioral events. They don't want to label kids as aggressive. That can come with a lot of baggage. I'm going to use the term patient aggression in this podcast just because it's more accessible for everybody else. But what we did was we were looking at what are the types of effects that people can have when they experience patient aggression. And does frequency matter? Or is it just really those huge events that really seem to be associated with psychological harm? We also took a look at what happens when you witness or hear about these events. And perhaps not surprisingly, but we're still pleased to find support for the notion that frequency of experiences, frequency of patient behavioral events or patient aggression is associated with worse outcomes, job-related outcomes, stress-related outcomes, and then job withdrawal and wanting to quit. And that this was true not just for when you personally experienced it, but also when you witnessed or heard about these events. And so we found some differential effects for nurses versus other healthcare providers. Nurses tended to have higher frequency of exposure because they're at the bedside so often. And we also found that psychiatric or behavioral health units and emergency departments were the units that tended to have the highest frequency of these events as well.
That is really interesting. And I think the differences of who's being exposed to these events more frequently makes a lot of sense, right? I think your point about nurses being exposed more just because they're at the bedside more makes a lot of sense to me. Also raises concerns and questions about like pay discrepancy, right? You're exposing a population to higher risk of behavioral events or patient aggression, right? That could be physically harmful, certainly psychologically harmful. Does that come with like appropriate levels of compensation matching that risk? Is something that like first comes to mind. And then also the idea of like where these are happening, right? Psychiatric or emergency departments made me think about like a handful of different nursing friends and colleagues and family members that I've talked to who end up bouncing around different disciplines of nursing. They get burnt out in one area and then go into like not gastronomy, that's working with food, gastrointestinal disorders, or they get burnt out there and they go to cardiac. And so I'm also wondering, like, you talk about turnover. Is it intentions to quit the career overall? Is it intentions to like just leave that organization or that unit and then maybe seek other sorts of employment? So I feel like there's so much to dig into here. For you, what are some of like the standout topics?
You're thinking about all the things that I love to think about with this particular population, and we could talk about this topic for so long. But I've heard anecdotally that there are a lot of healthcare workers who leave the bedside, and so they might work in another area in healthcare, leveraging their healthcare knowledge just in a different way to get away from these types of patient aggression experiences and just the general stress. And I think your comment about the pay discrepancy is a really important and a really good one. And I also know that some people just leave the profession altogether. Like they get so burnt out, they don't want to be involved in healthcare at all. So both of those things happen. Our data don't tease that apart in this particular paper, but I know that that's something that I've heard and read in the literature. In terms of what I find particularly interesting about the study that we did, is really helping people in healthcare, healthcare leaders, administrators, understand that the psychological effect of patient aggression experiences is not just centered on the person who was targeted by this behavior. So, workers' compensation data is going to really focus on the target, rightfully so. That's the epicenter. But what this particular paper does is it shines a light on the fact that witnessing and hearing about these events also adds to a person's stress. It also adds to their potentially wanting to quit the job or the profession altogether. And so there are these ripple effects that I think that a lot of leaders in healthcare may not really be aware of. And so that's the part that I'm most pleased to contribute with this paper.
That makes so much sense. And thank you for bringing us back to like the witnessing part of this too, because, I know in IO literature, we've seen like witnessing bullying or witnessing interpersonal mistreatment as some topics that people think about, which obviously makes sense, right? That reflects the climate and culture of the unit that you're in. So that witnessing experience also has like the moral component of should I have stepped in or not? In the case where, you have these behavioral events from patients, maybe there's not like the climate component of we as coworkers are treating each other poorly, and there might not necessarily be the moral component. Maybe there is. I'm not sure. I'm curious about your thoughts of like should I have stepped in or not. But to me, it rings almost of like social learning theory, right? Where I see like we are social creatures. I see this happen to someone else who is essentially in the same position as me. That could have been me. I don't want that to be me. What does this say? And then also I wonder too if that does like raise your antenna to see how the organization's responding. And I'd have to imagine in an era where like more and more hospitals are being bought by private equity, and we know some like economic level data that as you get bought by private equity, the nurse to patient ratio goes worse, up, down, the direction that's worse. And compensation certainly doesn't catch up. And so I'm wondering if like witnessing this, not only are you witnessing the event itself, and like that raises, through social learning experience, like, because we are social creatures, that raises like the it could have been me, but also if does that like tune in your attention to how is this being handled, how's the organization supporting this person? And my guess is like they're probably not to the degree that we'd want them to be. And so I wonder if that's like maybe a mechanism. And I'm sure like, well, I guess I'm not sure, but I don't think that your data can necessarily speak to that, but I'm curious like what your thoughts are.
So many thoughts, Keaton, so many thoughts. Yes to all of this. So I definitely think that people look at these experiences when they hear about them, they witness them, they think that could have been me. And that increases your concern, your stress, your fear. So I think that definitely happens. I think there's an empathetic response. This is my friend. Somebody hurt my friend. So a lot of times we're friends with our coworkers. And so you don't want to see anything bad happen to them. So I think that's important. And I also 100% think that people look at what happens. In what way is this person supported? This is social information that you're going to use to make judgments about whether you think the organization has your back or not. Does the organization really care about you? And it's a great segue into, I hope to be a guest in the future, talking about some research that I'm doing right now related to peer support programs in healthcare. And so these are programs that are designed to help mitigate harm after exposure to primarily what they call second victim experiences. So witnessing something terrible happening to a patient. but we are working on expanding that to cover patient aggression experiences, to teach peers how to provide that kind of support to help mitigate the harm. And that's one way that organizations can show that they support their workers is by having a robust peer support program that offers the peer supporters well-rounded training.
Well, that answers my next question, which is like, what should we be doing about this? Because like the answer I don't think is like, don't have nurses or like quit the job or friends.
Yeah, the real answer is don't have patients.
Yeah, that solves that. Oh my God, duh. Healthcare without the patient seems pretty ideal.
Pretty ideal. It's the easiest job ever.
Yeah.
And I think one of the things that I found so inspiring, I have to give a shout out for healthcare workers. I was talking to a nurse manager who was in charge of a behavioral health unit, right, or a psychiatric unit. And some of the nurses came to her and said, I don't know why we have to have this patient. This patient is so aggressive. We should fire this patient. This patient shouldn't be allowed to be here. And the nurse leader said, the reason that this patient is here is because this kid really needs our help. This kid deserves great care, and there is no better place for this kid to be than here because we can provide the best care for this kiddo. And when I heard that story, it just gave me goosebumps. The type of work that they do is so difficult. I'm really, really motivated to try to help support these healthcare workers doing these jobs that are so incredibly difficult. Now that I have told you this story,
I love this story. And it, you know, makes me think if we can go down a tangent real fast of, again, going back to like the compensation side of things of like pro-social work and highly meaningful, like calling oriented work. And then certainly care oriented work, which we know is like largely women dominated professions, tends to be underpaid because you can count on the people in those careers having that sort of reaction of like, I'll go above and beyond sort of the expectations because this is so meaningful. This is so important. Our customers, our clients, our students, our patients deserve this. But then you end up with a bunch of people who are burnt out and not compensated appropriately for that. And so I love that story. It's, very inspiring. These workers themselves are very inspiring. But then from like an organizational perspective, I don't think we can rely on or ought not rely on the meaningfulness of the work as the compensation, And I guess the question that led you to it was, what should we do about this? And maybe that gets wrapped into this broader, what should we do about like this?
And I'm so glad that you brought that up because I feel both of those things very strongly. I'm super inspired by the work that they do and by the selflessness and the way that they are able to give so much to their patients. And at the same time, I think it is extremely important to make sure that these workers are compensated well, that they are protected well, that they are supported in this work to make sure that they are not burned out because that's not good for anybody. Okay, that was obvious. But I'll back up. Hospitals have a lot of ideas for how to reduce patient aggression, prevent it from happening, which is, of course, the best possible thing to do. And so they're working on these ideas. And I didn't feel like as an IO psychologist that I necessarily had the knowledge or the skills to be able to help them with that. They feel like they've got it well in hand and they're trying out these ideas about emergency response teams and better communication about aggression risk through the electronic medical records, for example. So they've got a lot of ideas in the hopper. The reason that I am now studying peer support for healthcare workers is because they had many fewer ideas of once this happens, what do we do? How do we show our support? How do we help people recover in a way that keeps them from getting burned out, in a way that keeps them feeling like they're connected to what's important in their work and what's meaningful without feeling like they are depleted and they can't rest and recover. And so I think that that's a really important part of it. And you really need all of these things on board to make sure that healthcare workers are getting the support that they need for the important work that they do.
I love that. Just innately tapping into that public health model that I think we've talked about a handful of times on the podcast before of, certainly primary interventions trying to reduce exposure to the stressor or to the hazard, in this case, patient aggression. But then, we can't prevent every incidence. So when you do have that exposure, how do we mitigate the negative outcomes? What can we do to reduce, the likelihood that it results in injury or psychological injury? And then, what do we do once it does? How do we get you back on your feet after you've been burnt out? How do we get you back on your feet after you've started to tip into, negative feelings towards your job, towards your patients, towards the organization, towards yourself, potentially even? And I like that the notion of staying in our lane, our scope of work means sometimes we're not speaking to reducing those primary stressors or hazards, but we can really add a lot here to those secondary and tertiary. At least in this case, that makes a lot of sense to me. And I like that you have that holistic model. And it sounds like a good way to communicate that to the clients themselves. Doing this research, did anything surprise you?
I think the fact that I'm doing research on patient aggression surprised me. So let me tell you how I got involved in that, because that wasn't my goal. I got connected with this group called the Solutions for Patient Safety. Huge shout out, incredible consortium of children's hospitals trying to just reduce harm across all these children's hospitals. And they have had incredible luck with patient safety. And they've decided, in 2017, decided to tackle employee and staff safety. And that's where I got connected because I'm a safety researcher. With some experience with healthcare workers, so I was a good fit. And I assumed, because of my previous interest and reading and exploration, that I would be looking at what's called safe patient mobilization. How do you move a patient without throwing out your back, or wrenching a shoulder or something like that? And, I asked the question, what is it you guys are most curious about? Where do you think the information is the least available? And everybody that I asked this question to always without hesitation said patient aggression. And I kept asking it because I wanted a different answer. I wanted them to say, there's a lot in safe patient mobilization that we're really curious about, but they weren't. And so one of the things that I'm really happy about is that I listened to what they needed and decided I can go learn about that. I don't know about it, but that's part of what IO psychologists do, is we go and we learn things in new areas. So I learned about patient aggression. I am also partnering on this work with a clinical psychologist, a pediatric clinical psychologist, who can help out with the areas that I'm not strong in, like trauma-informed care. And so I think these kinds of collaborations also help to strengthen the work that we're doing in this research program.
Amazing. I love that story. And it is one of the reasons I got into IO in the first place, was to have a foot in the healthcare field and make sure that, lives that are being treated by healthcare professionals are being done so in the best way possible, but also to be able to keep trying on different hats and learn more. And I love that you've embodied this, especially the listening part of listening to the people who have their feet fully in this world and know the problems themselves, right? We hear a lot about parachute research, where you parachute in, you come solve a problem that you were interested in, and then you leave, but it didn't actually help the people that you were doing research with or consulting with in the first place.
Exactly.
And I absolutely love that your approach is not that. So I get to ask you my favorite and final question. Lisa, why do you do this work?
Okay, here's the joking answer. I am too chicken to be a healthcare worker. That's so much pressure. That's so much. And the idea that if I make a mistake at work, people's lives are in the balance that's just an enormous burden. And I like being backstage on that. So I kind of consider myself to be the tech theater folks behind the healthcare workers, helping them and supporting them in being able to do their job better. I would say the maybe more serious answer is that I am really motivated by the work that pediatric healthcare workers in particular, but healthcare workers in general do. It's incredibly challenging, incredibly important work. And I love to be behind the scenes as a voice saying, hey, these healthcare workers are super focused on their patients and they forget to focus on themselves. I'm going to be the voice behind the scenes that says, let's not forget to take care of the healthcare workers. It's just a great spot for me. It's a message that I love to send. And so that's why I think that this work matters, is I feel good about supporting people who are really deserving of our support.
I love that. Well, thank you so much for your work. Thank you for your time, and I'll talk to you soon. Bye.
Wonderful. This has been great. Thank you so much, Keaton.
Healthy Work is a podcast written and executive produced by Keaton Fletcher and Mariana Arvon. This episode is produced, mixed, and edited by Keaton Fletcher. Artwork is by Keaton Fletcher. And our music is Zero, Microsong by Steve Combs. Please like us, follow us, and subscribe on whatever podcasting software you use. And please leave a review on the iTunes store. It really does help get us out there.